So welcome everyone to our NCCDH webinar today. The title of our webinar is Moving from Equity of Care to Equity of Outcomes, Strengthening Organizational and Health Systems Performance to Report and Act on the Social Determinants of Health. We are really excited to welcome some guests who I'll be introducing in just a moment to help us explore this topic. A lot of what we're going to be focusing in on today is the accreditation process and questions of quality and quality improvement, which we've been hearing from our colleagues in public health across Canada is an important topic as everyone works towards strengthening the social determinants of health and improving health equity. So welcome everyone today. If you have any difficulty hearing us, please do put a note in the chat box and we'll see what we can do about that. All the audio is happening on a teleconference number, not on the Adobe Connect sound system through your computer, so you may want to mute your computer so you don't get any feedback. I do have all the teleconference lines on hold, on mute for everyone except for the presenters, and just to keep everything really quiet because we are expecting about 100 or so participants today. So just a reminder about the chat box. You should be seeing all the different postings going in there right now. It's on the left of your screen. Please at any point put anything in the chat box, a difficulty, a question, and please put questions in as we go because we'll be pausing periodically to check in with you about questions for clarification, and then we're going to be going into a discussion for the last 30 minutes of our webinar today. So I've advanced to slide 4 for those people that aren't on the Adobe Connect, and slide 4 is a poll question. As I said, we really would like to know where you are attending from. And so we have a little checkbox where you can just go up and click and indicate where you're dialing in from. So if you could go ahead and do that, and everyone should be seeing the information populate. What I'm seeing right away is we have lots of friends in Alberta. That is great. I know that there's a really special interest in this, and I focused on promoting this with my Alberta colleagues really intentionally. Lots from Ontario as well. And then we have Nova Scotia, PEI, Newfoundland, British Columbia, Saskatchewan, Manitoba, and of course from the U.S., which includes our guests today. Oh, we have someone attending from Europe, so welcome to everyone. All right, so we're going to close that poll, and I'm going to move us on to the next poll. Very quickly, we just want to know what sector you're from. So this will really help us as we think about the information that we want to share with you today. So you can see the same format. If you can just take a look and give a click and tell us what sector you're coming in from. And if you click Other, it would be really helpful if you drop something into the chat box so that we can see what kind of other departments or sectors we're attracting onto the call today. So you can see there's lots of public health management folks, which makes good sense because accreditation is an important part of the management role in public health across Canada. Healthcare, college, university, frontline public health, and then a couple of others. So thanks very much for that. All right, so I think we need to get to the meat of our presentation as soon as possible. So I'm just going to do a little bit of introduction, and then we're going to get right over to our first guest speaker today. So my name is Leslie Dyke. I'm a knowledge translation specialist with the National Collaborating Center for Determinants of Health. And I'm being ably assisted by many people behind the scenes, but in particular my colleague Diane Oikel, who is going to be making sure that the chat box gets managed, and we'll be adding a lot of links in there. So please don't hesitate to add links yourself in the chat box as we go. I'm also really pleased to welcome our guest presenters today. When we decided that we wanted to focus in on accreditation and quality improvement, it was in some ways a bit of a no-brainer as to who we wanted to go and hear from. We put the biography information for all of our presenters in our invitation, so I would encourage you to go over there to read a little bit about their backgrounds. But I want to welcome Robin Wilcox from the Public Health Accreditation Board. They've done some fabulous work at the board of really intentionally integrating equity, and I'm really thrilled that she could be here today. And she suggested that we include some really frontline practice example from a county in the United States that has been through the process. So I'm really pleased to welcome Julien, who is with the County of San Diego, and she's going to provide some stories, some experiences of what it was like to go through this accreditation process, because it is fairly new in the United States. And I also want to welcome Sharon, and I know that Hannah is lurking in the background there. Okay, she's probably not lurking. Colleagues from the Winnipeg Regional Health Authority. So Sharon's Kuropatwa is going to be helping us by sharing the experience that Winnipeg went through with accreditation on a relevant standard from Accreditation Canada. So really, really pleased that everyone could join us today. So the National Collaborating Centre is one of 6 national collaborating centres in Canada. We are basically knowledge translation, knowledge mobilization units focused on supporting public health across Canada. We're located in Antigonish, Nova Scotia, although our staff are located across Canada, which is why I am calling in from British Columbia today. And the focus of our specific collaborating center is the social determinants of health and health equity. And what we're trying to do is we're trying to support our public health practitioners across Canada with the resources and tools and capacity they need in order to integrate health equity interventions that are focused on addressing social determinants of health. But we also act as a bridge between research and practice, and we spend time with practitioners or with researchers as well, helping to capture and translate their research and help them understand what practitioners are looking for. So that's the role of the National Collaborating Centre for Determinants of Health. Today, we're going to do a few things in this webinar, and our guests are going to help us with this. We are going to be exploring in a bit of detail what the Public Health Accreditation Board has learned in the United States around through their first 3 years of implementing their accreditation standards, but with a particular focus on the equity perspective. We're going to hear some stories from the County of San Diego about what it was like to go through that, and in particular, what the impact or engagement has been around equity priorities for them. And then also we're going to get some reflections from the Winnipeg Regional Health Authority about their process and how it's part of their health equity work, because they've been real leaders and champions in Canada on this kind of work. And then we're going to wrap up with about, we're hoping, 20 to 30-minute discussion to explore the role of quality improvement in accreditation processes to support action on health equity. And that's where everyone on the call today, we're really going to be relying on you to ask the questions that are burning or important for you, but also for you to put forward some of the ideas or experiences that you've had. So please keep adding to that chat box as we go so we get a sense of where you're at with respect to this topic. So just before I turn it over, I just have one little other piece to do, and that is to share a definition of health equity. And we do this all the time, in part because we recognize that there's many different understandings of health equity. So one of the projects we undertook here at the National Collaborating Centre for Determinants of Health was to come up with a general definition, an easily accessible definition of health equity that we use in our work and has been, I think, well accepted across Canada. And I would just note that point, because the way that health equity is used in the United States, I think we're going to hear it's a little bit different. So that will be another really interesting learning for us. So our definition of health equity is that health equity means all people, individuals, groups, and communities have a fair chance to reach their full health potential and are not disadvantaged by social, economic, and environmental conditions. And you can find other definitions related and linked with this definition in our glossary. So I'd encourage you to go there and take a look at our glossary. So then, without further ado, we're going to just do one more little poll. And this poll is so we can get a bit of a sense around your involvement in accreditation work. So the first part of this poll is just to find out from you, have you participated in an accreditation process as part of your work? So I just want to get a sense from the people on the line how many have really stressed through the accreditation process, because anyone who's been through it does know that it's quite intensive and can be stressful. All right, very nice. So we've got about 2/3 are saying yes, and 1/3 of respondents are saying no. Okay, thanks very much for that. And the second part of our question is related to your accreditation experience for the 2/3 that have. Did this accreditation experience have a focus on equity issues? So if you could just reflect on your experience, did your accreditation experience have a focus on equity issues? So I'm seeing one response, 2 responses saying not sure, and I'm not surprised about that, because sometimes it's a little bit hard to see equity embedded in accreditation. I'm seeing almost 30% of respondents saying yes, and then the majority, over 2/3, saying no, it did not have an equity focus. So thanks very much for that. That helps us, as we're providing some examples today, pitch this to the right level. All right, so I'm going to take us to the first slide from Robin Wilcox, and I'm going to turn this over to her to share her experience and things that she thinks might be helpful for all of us. So go ahead, Robin.
All right, thank you so much, Leslie. The Public Health Accreditation Board, we call it PHAB, is the organization that accredits public health departments in the United States, and public health departments are governmental organizations, and it's a decentralized system, so they're at the state level and the local level. We incorporated in 2007 and started accepting applications in 2011, and we have 151 accredited health departments. We're a pretty new organization, but we're really pleased to have that many accredited health departments. And we have another almost 200 officially in the system seeking accreditation, and we get new applications every day. Just as the context, a little bit of background, our standards and measures that we use for accreditation are grouped in what we call domains. And the first 10 domains of standards relate to the 10 essential public health services. And then we added a domain of standards about administration and management and a governing entity. And each domain has some number of standards, and then each standard has some number of measures. I do want to just note that our standards and measures for our public health accreditation does not address clinical care or individual patient care or associated interventions of clinical care or individual patient care. And I know that's a little different. We do have particularly local health departments that provide clinical services, but for PHAB accreditation purposes, we don't accept documentation or examples from clinical services. So that's a little different because, as you know, in the United States, for the most part, clinical services are provided by private, not-for-profit or for-profit organizations, and public health services are provided by governmental organizations. To give you a little background of what we've been through with the standards and measures, we released our first version of standards and measures, and we incorporated what I think of are many of the tools used to address health equity throughout the standards and measures, but we didn't address health equity specifically, except in the one place where we require that health departments develop a community health assessment and that they describe issues of their community, including health status disparities, health equity, and high-risk populations must be addressed. So it was in the first version of the standards and measures, but not really evident. But 2 years later, we decided that we had learned enough in that short period of time to revise our standards and measures and tighten them up and add some really important requirements. And one of the areas in which we added a number of requirements was around health equity. In a number of places, we didn't want to use the term health equity because it has some, it's a little bit of a hot button issue for some communities and some people. So a number of places we use the term populations at higher risk for poorer health outcomes. So that's sort of our phrase meaning health equity. But we also addressed health equity directly in many cases. We actually used the term specifically 41 times. I went in and did a word search and counted it up. We adopted a brand new measure in our version 1.5 that addressed health equity, efforts to specifically address factors that contribute to specific populations' higher risks for poorer health outcomes, and called out health equity in that we require health departments to do an analysis of factors around health equity, that they do public health efforts to address it, and that they have internal policies and procedures to ensure that programs address health equity. And then I just wanted to review a couple other places that we call out health equity. In addition to a community health assessment, we require that every health department, and this is a community process, conducts a community process for its community health assessment, but then a community process to develop a community health improvement plan. So this is not a plan about what the health department is going to do. It's a plan about what the community is going to do, and the health department is one partner in those efforts. And so we included the requirement that what we call the CHIP, the Community Health Improvement Plan, include policy changes. So not just, oh, you're addressing health inequities or you're addressing disparities, but that you include in your plan actual policy changes that you will work towards in your community to alleviate the identified causes of health equity. In another place in the standards and measures, we require that health departments review laws in order to determine needs for revision, and we included that when they do that, they specifically consider the impact of those laws on health equity. A couple other places. We require that health departments provide a policy or procedures that demonstrates how they incorporate health equity as a goal in the development of all of their policies, programs, and processes. So we don't say it this way, but in effect what we're saying is when you're developing policies, processes, or programs, you should run it through a health equity lens and make sure that you're addressing health equity. In the domain of standards that talks about how the health department operates, we require that they do an assessment of their own cultural competence, and with version 1.5 we added a knowledge of health equity, and included in that is a requirement that they develop and provide training for their staff around cultural competence and health equity. So that's a very quick overview of how we've incorporated health equity into our standards and measures, and we hold health departments to provide us with documentation that they actually meet those measures. And we have trained site visitors that review the documentation and go on site to the health department and ask questions and then develop a site visit report, and then it goes to a committee that reviews the site visit report and decides whether a health department is accredited or not. We're coming up to the first health departments that will apply for reaccreditation in about another year. So we're developing a different set of reaccreditation standards and measures, and I will tell you that we're incorporating and strengthening the requirements around health equity for reaccreditation a great deal. We're saying, okay, these health departments are accredited health departments. They've been reporting to us every year for 4 years. Now they really have to kick it up a notch in terms of health equity in order to be reaccredited. Thank you very much.
That's great, Robin. I'm sure we're going to have a lot of questions for you. The contact information is in the slides on slide 22. But just before I open it up or check in with the chat box to see if there's any questions for clarification for Robin, I do have a poll question for you. And this poll question is based on what you just heard Robin talking about. And I would like to know, we would like to know from all of you, which of these standards that she talked about and at a very high level are reflected in some way in the work of your public health organization. So you're going to be able to choose more than one of these if there's more that apply to you. So if you can just indicate which of these are most relevant, that would be really helpful. Okay, so Anna's got it over there, and I see some comments coming in. Certainly the identification and implementation of strategies to address factors that contribute to specific populations, higher health risks and poorer health outcomes, or health equity. That is absolutely, 70-some% are identifying those as standards that are part of their public health, your public health work. The second highest ranked one is the health equity and cultural competency training provided to health department staff. That's also quite significant, as well as community health improvement plan, which I have to say I'm really pleased to see that there's some responses like that, because that's actually not been a strength of public health community engagement in Canada, so that's great to see. And then a few people are not sure, so we've got nine people that have said they don't know. So thanks very much for that. I am going to close that poll now and just check over at the chat box. Are there any kind of questions for clarification before we move on and hear a practical example of a health department implementing these? So I'm just looking over. I don't see any questions specifically for Robin, so I think what I'm going to do is I just advance to the next slide, which is the first slide from Joanne, and she's, as you can see, from the County of San Diego, and she's going to share a little bit about what it was like to go through this accreditation and some reflections from a health equity perspective. So Joanne, can I pass it over to you?
Yeah, thank you. So I'll say good morning, good afternoon, or maybe even good evening to everyone, depending on where you're coming from. I'm really excited to get the chance to talk about this. This is one of my favorite subjects. My challenge is going to be to keep it to 10 minutes, because anyone who knows me, if you give me the floor, I'll be happy to talk about this for much longer. As you may have noticed in my write-up as well, I'm a dual citizen between the United States and Canada, so I've actually had the opportunity to work in public health in both countries. I used to work for the Public Health Agency of Canada, and now I'm with the County of San Diego's Health and Human Services Agency in public health services. So I'm happy to lend that perspective as well. But specifically today, I'm going to pick up from where Robin left off and talk about how we took their standards and measures and then brought them to life. And specifically, I'll give you examples, not just of all the great and wonderful things, but also I was asked to give some really tangible, real-life challenges that we faced in implementing those standards and measures, and I'm happy to share those behind the scenes, kind of what we really lived on a daily basis. So to begin with, the next slide here shows you the group. So you can see we were accredited May 17th, 2016, a day that was burned in our minds. We have lots of pictures all over our office about it. It was a very exciting day for us. We have right in the front center, that's Jackie Worth with the blonde hair glasses, sort of sitting in front of the sign. She's really was instrumental in bringing about accreditation for us, so I throw that out there as a kudos to her. And also on the far left-hand side, you'll see Nora Bota, and then right behind Nora, that's our fearless leader, Dr. Wilma Wooten, who asked me to make this presentation for you today. I'm over there holding up the sign on the right-hand side with the navy blue suit jacket, blonde hair, and that's not all of us in the picture. There's a lot of people that contributed to bringing about accreditation, but these are some of the, definitely a lot of the key people that helped with that effort. So how did we bring it about? Well, Robin made mention of the policy and how important it is that you have a policy in the department that will explain to people how to bring health equity to life. So we did develop 2 key products, and it really took a pretty big effort across all of our branches to design not just the policy, but also the precursor to the policy, which was our plan. And this is a copy of the plan itself, and you'll see it's very recent. But a lot of work went into looking at what other people had done and what the key components needed to be, both of the plan and the policy. But we feel pretty good that by taking these major components and then operationalizing those, that we would be in alignment with the PHAB standards and measures. And just to point out kind of one key area here, we talk about organizational or internal transformation, and this was really not just important historically, but it continues to be important to us today, and I'll share a little bit about that in a minute. But this, to be specific, points to workforce development. So we really felt strongly, and it's reflected in lots of literature, that it's not just an external activity, that internally the staff need to understand, embody, and really have infused the values of health equity and an understanding of the social determinants of health in their work, so that we're all singing from the same song sheet, that we understand how it affects all of us and how we're all contributing to the same broader goals. So a lot of our effort, and you'll see this coming up on future slides, is about the engagement of our own staff in this journey. So policy development would be a next key piece. Oh, this slide here will show you just how we took the major components of our plan and aligned them to the PHAB standards and measures to make sure that our plan, which is a 5-year plan, includes all the pillars and elements that Robin was discussing earlier. So this slide here shows you, again, this piece comes from my boss, Dr. Wilma Wooten, and again, talking about those key pillars and how does this align to other things. So for example, if you look on the right-hand side, you'll see reference to WRHA, Office of Minority Health, NACCHO guidelines. So we didn't create our stuff in a vacuum or even just exclusively with the PHAB standards and measures. We did look even more broadly and globally to make sure that we had all the key components included. This is a copy of our policy on health equity and cultural competence, and it does exactly what Robin described. It tells everyone who's an employee of our department how we're going to do it, who's going to do what, and it covers everything, from policy, communications, health promotion. It really soup to nuts, all elements of our business are sort of covered off in that one policy. And then we pushed this out through a system that we have called Policy Tech, which is a policy development software. So, for example, if I want to make sure that everybody in my department reads it, I basically tag them or assign it to them, and then they get these annoying notifications until they finally read it. And I have a report that tells me who has and hasn't read it. So we really made sure at the outset that we were all of the same understanding about what health equity is, how it's defined, and what it means specifically for us in our work. So this is one of my favorite slides here, and one of the more fun ones, because this really shows you in practical terms some of the things that we did, not all of them, but some of the things that we did to bring life to what Robin described. So in terms of engaging our staff, we developed a Health Equity 101 training. And I have to say about that one, because this was an interesting conversation, we were getting asked by staff, I don't know if I'm revealing something here, but some people didn't know what health equity had to do with their role and function in the organization. They weren't sure. And so our committee decided that if people didn't understand that it was integrated and it was, you can't even talk about public health without talking about health equity, maybe we need to back up a little bit and teach people who may have come to the department from other disciplines, we needed to give them a Public Health 101. And there's been other research that we've seen that shows that I think at the state and federal level in the United States, only about 17% of people that were working at those levels had public health degrees. And so we're not sure what it looks like. Maybe other people know at the county level, but we figured if that's the rate at higher levels, probably for us, most people here don't have a public health, at least, they have a background, but not necessarily a degree in it. So we developed a really great Public Health 101 that talks about the history of public health, key concepts and context, and some data slides. So that was the precursor, and then we had our Health Equity 101, which also included, and this was a sort of request of the staff, they said, I get this, even if I can get it conceptually, I really want to understand as a public health nurse, what do you want me to do differently? What am I going to be saying to my clients this afternoon that I wasn't saying to them yesterday? So they said, really, can you make this very practical? So we included in our health equity training what we're calling a self-assessment tool, which gives people very tangible, practical things you can do this afternoon to make health equity happen or to help bring it about in your role and function. So I'm really proud of that. We also have hosted a number of webinars. Specifically, there were 6, I think, that came out of the American Public Health Association about health equity and racism and how racism impacts on public health. We're part of a town hall, which brought together some really great speakers, the president-elect from American Public Health Association and Tony Eiton, also fellow dual citizen from Cal Endowment, did great presentations, and we had a lot of people from the community there where we were talking about these issues. We also work with the state level. So in California, we have the California Department of Public Health, and they have an Office of Health Equity, and they developed a statewide plan. So when they were launching that, we said, why don't you come to San Diego? And the day of the launch, when their statewide plan went live, we had a representative from the office here to share the plan and see how we could be involved with their plan and bring that to life as well. We also just recently launched our READY webpage, which is reducing and eliminating health disparities and inequities. And then one of the really amazing things, and for those of you who like epidemiology and data, you'll love this, but on our website, our Community Health Statistics Unit published what we're calling our equity report. And that's where we look at the population as a whole through different lenses of equity, and we show how we're doing as a county in terms of any disparities that we're seeing in our population. So definitely, if you're interested, let me know, and I can lead you to that, or you can just check out the Community Health Statistics Unit website and look for equity report. And then on this slide, and I'm probably already running out of time, but 2 of the things I'm most proud of are in red. So we had a day of celebration. And this was completely gratuitous. This was outside of our plans, but I learned that in November there was a Day of Tolerance that the UN was celebrating, and it just so happened to coincide. We were launching a diversity and inclusion strategic plan. So I said, why don't we bring together all of we have these employee resource groups that, for example, like an African American resource group, a Middle Eastern resource group. So we said, why don't we bring all the people together that have an interest, and why don't we have a day where we just have a celebration of equity, inclusion, and diversity. And you'll see in the top of this slide, there's some dancers. They can't this is free. They just came on their own to volunteer to put on, this are people that came from a Mexican dance troupe. And we had food from all over the world, and we had a number of different speeches. On the bottom right-hand side, you'll see a mosaic that was created. We made that during that event. Anyway, so I thought that was a great, very positive experience for everybody, and it was really an opportunity for people to dialogue and discuss what we were all doing in our respective silos, because sometimes people tend to work, as you guys well know, sometimes separately. So we also featured Jen Silent, which is an amazing, wonderful video, and we did a book review on Black Man in a White Coat to talk about racism in medicine. And then I probably have like about a couple more minutes, but the workshops, I want to talk about that just a wee bit, because this is a more recent thing. So we challenged our chiefs to present their disproportionality and disparity data, and then we wanted them to develop an action plan and a set of metrics to measure to show that they were moving the needle in terms of achieving health equity. And they found that was challenging, one by one they made their presentations, and it just so happened that the state offered to come down and do a workshop for us on something different. And I said, well, wait a minute, would you be willing to take your this opportunity and turn it into a workshop for our chiefs on how to convert their disproportionality and disparity data into action plans and metrics? And we'll give you like 6 weeks to review their PowerPoints, but could you come prepared to like roll up sleeves and really work through this with everybody on a very practical level? So on the 10th of October, we had our first pilot workshop on action plans and metrics, and it was a great success. I mean, people really from all branches, all disciplines, EPI, health promotion, different branch chiefs, data people, communications people, all worked on one topic as a starter. So we did HIV and STD branch, and we looked at disproportionality and disparity in various populations that are experiencing, because you might, I don't know if you saw recently, this CDC published a report saying that STD rates are astronomical right now, not just in the U.S. but also in San Diego County. So this was very timely, and the people who came from other branches said, can you also do this for us? So now we're going to do TB next, maternal, child, and family health, and it's a really great way to not just talk about health equity, but to actually say, what do we want to do about it, and then let's set some markers and indicators, and then let's track our progress to show that we're actually doing this. So I wanted to just point that out. And then there's a number of other things that we did additionally to make it come to life. So that's the positive side of the story. So I was challenged to come up with like, tell us what was like, difficult about it, or what were the opportunities for improvement. And so these next two slides, one says opportunities, and I think the other one talks about challenges, but they're basically both challenges to us because we really don't have a huge department. And you probably noticed in the first slide, that's not a lot of people. And although Robin mentioned that they don't cover health services, we have a lot of staff in our department that are nurses and communicable disease investigators. We have a TB clinic, we have an STD clinic, we do birth and death certificates. We have a lot of practical staff. So for us, one of the challenges was just around workforce and implementation of this, but I'll get to that in a minute. So this slide tells you a few of the things. So when the PHAB reviewers were here, they noticed that San Diego County is really amazingly diverse. I mean, there were so many languages, so many cultures, a real mix of things going on the ground, and they just said, you guys, you do a great job, and just keep up, that focus on cultural competency, because it's something that's going to remain important, and so definitely you want to stay on top of that. So we committed this year to have 90% of our staff all make sure that everyone has done an additional cultural competency training. So if you haven't done the 101, you would take that. If you've done the 101, then we have a menu of other options. But everybody was going to do 4 hours of cultural competency training this year. So I'm arranging that. And then they said we had a great workforce development plan, but we didn't have a work plan to support it. So there was no traction there. So we have subsequently developed a really comprehensive work plan for workforce development, and that's one of our main focuses for this year. And then finally, they talked about this culture of quality assurance and quality improvement, and just those plans and metrics, and really making sure that everyone's educated about how to do that. And I referenced those plans and metrics that I was excited about, and that gets at some of that, at a great deal of that. So that's a good start. And then because of all that we did last year, we were actually able to get all the chiefs to agree that all their branches would do these things together in 16-17, including the training, the action plans. I've also developed a policy on trauma-informed approach, and so that's been approved, and we're going to launch that through Policy Tech. and we also agreed that we're on the border of Tijuana, so we have a binational strategic plan, and there's a lot of activity there. So if we wanted to make a dent toward health equity, anything we could do toward this plan would go a long way. So we got everyone to agree to help with that. And then finally, this is really the real story here. Because we have we're not a lot of people, and we do have these essential services that we are required to deliver. Sometimes there's these competing priorities, and people have said one of our greatest challenges internally is our workload to staff ratio. And I'm sure this isn't new to people who work in public health. I've worked in public health almost 20 years, and everywhere I've ever been, we've had a workload to staff ratio issue. I don't think it's unique to us, but it's an issue because at any given moment, whatever we're working on, we're supposed to be working on 3 other things, and there's a lot. And so keeping people's attention, keeping their enthusiasm up for things like health equity that might seem not essential to their core function, if they're a nurse or something, that's a challenge, but I think we've done that a pretty good job. In terms of making sure that people see how this relates to their job function, that was a challenge, but I think we've found some workarounds. And then finally is just there are multiple internal and external forces that are impacting on outcomes in general when it comes to disparities and equity issues. Just, personal example, my rent is ridiculously high, and half of my paycheck pretty much goes to pay my rent. And so I'm left with whatever the other half is for a family of 5. So that's a factor that, it just affects what people have in terms of resources. And that's not just a personal story, that's across the county. We're challenged by, the high rent and salaries not being, as high as they might optimally be to meet everybody's needs. So housing and economic realities and those kind of external forces, those things impact on health equity, and not all of which are directly in line with everything that I can affect or that each of us can affect. So that's just something that we continue to be challenged by, but we have plans in place and a strategy for Live Well San Diego, which includes a broader look at all things that impact on health. And if I had more time, I could talk to you about Live Well San Diego, but I don't. I'm happy to come back and talk about that another time. And thank you very much for your attention.
That's great. Thanks so much, Joanne. Lots of good stuff in there. And we're getting some good questions in the chat box, which I think are going to be broad and apply to all of our presenters today. Certainly questions around building public health capacity and about public health practitioners. Who are they? What are their skills? Questions around data and the importance of using data. So those are all great. We're going to get to those when we get to our discussion section. So if there's any questions for clarification for Joanne, which we can put to her now, if you can just pop those into the chat box. But while we're doing that, I'm going to move us on to a poll question. And this is directly related to some of the challenges that Joanne identified. So she identified competing priorities, workforce development, documentation, data, and tracking as challenges that are important that she hadn't, there were issues for them in San Diego. So I'd like to know from you, from everyone on the call today, which of the identified challenges do you feel would also be relevant in your public health organization? So I'm sure Anna will drag that over in a second. Yeah, thank you, Anna. So there's the poll. If you can just click on, you can choose more than one, whichever ones you think are relevant to you. And a couple people have said other. So if you have a chance and can put other into the text box, the chat box, that would be great. We can get some ideas of other challenges. No one said they don't know what the challenges are, which I'm not surprised about. Okay, I'm just looking over into the chat box to see what kinds of clarification questions there would be. Again, more questions around policy and questions around engaging with community collaborators, partners in the community. So I think we'll save those for the very end because I think they're going to cut across all of the presentations today. Okay, looks good. All right, so let's close that poll. Thanks very much to everyone. All of those challenges look relevant to pretty much everyone. So I think in many ways we're in the same place on this, whether we're in San Diego or in a health authority or health unit somewhere in Canada. So thanks for that. And so with that, we're gonna move to a Canadian example to our friends at the Winnipeg Regional Health Authority, because they have been through an accreditation that had a particular focus on health equity, and they learned some things in going through that process. And it will really help us then to see the Canadian context around accreditation and the processes, which will answer, I think, some of the questions we've been getting so far. So I think what I'm going to do is just turn it over to Sharon and ask her to go ahead. We're going to take this conversation until shortly after the top of the hour, so I'd say till 5 past, 10 past, somewhere in there. And then we're going to open it up for discussion, and we're going to get all these questions that you've been posting to our presenters today. So Sharon, over to you.
Thank you, Leslie. Good afternoon, good morning, wherever everybody is. Thank you so much for joining us on the webinar today. We're talking about an issue today that we're particularly passionate about here in Winnipeg. I want to just highlight for people what we're going to do in this 10 or 15 minutes we have to talk about. We're going to talk about our experience with Accreditation 2016. I think that'll be particularly interesting for folks. I see in the chat that we've got some people from Alberta lined up to do their own accreditation coming up. So this will be a good opportunity to kind of learn some of our lessons from our own experience. We're going to explore the opportunity that the Population Health and Wellness Standard provided for us, highlight the interplay between our strategic plan and health equity, and then focus on some of the quality improvement initiatives we've got going in support of these efforts. So starting with our experience with accreditation in 2016, this was the first time for the Winnipeg Regional Health Authority that the entire health region was reviewed at one time. Normally we'd have 4 or 5 areas or population focus, and we would do that in a cycle of every 3 years. This was the first time that every site and every program was accredited at once. It was a really fascinating experience. It was galvanizing in a lot of ways in that people from wherever you went in the health region, whether you went to an acute care site or a community health clinic, everybody was engaged in this process. So it did bring people together around that. That was really neat. In Winnipeg, in Manitoba, the Winnipeg Health Region also has responsibility for the Churchill Health Region. So we were working far south in Winnipeg with our programs, as well as our farthest north health center in Churchill, all being accredited at one time. It was kind of a fascinating opportunity in a lot of ways. The Population Health and Wellness Standard was new for us. It did give us an opportunity to look at how we want to improve around a particular population issue and what tools we might need to do that. In the next slide, you can see that we're looking at investing in population health and wellness services, integrating, coordinating those services, basing decisions on research and evidence, using information technology, and monitoring our outcomes. None of that is new. What was really new was what population we focused on. So that was an opportunity. We were able to develop our own focus population, and it was really different for us to be able to look at, are we looking at a group of people with a particular disease or a chronic condition? Are we looking at a particular program? But looking at what the Population Health and Wellness Standard asked us to review gave us the opportunity to think a little bit outside the box. How we organize ourselves, how we use information, where our programs and services are, and how we monitor. That gave us the idea that maybe what we really want to be looking at is something different, kind of an unusual suspect. So the unusual suspect that we chose for the Population Health and Wellness Standard are individuals living in the social and economic margins, especially those at risk for or experiencing homelessness. This, in a lot of ways, was a really brave move on the part of the Winnipeg Health Region, and I say that because we didn't think we were going to do very well. So normally we look at accreditation processes as a bit of an examination process, and you want to do well. You want a good score, you want lots of greens, not so many reds. While we talk about accreditation as a learning and improvement opportunity, programs and sites and staff tend to really see it as a bit of an exam, and you want to pass, you don't want to fail. Well, when we looked at what we were doing in our early days, maybe 5-6 years now, we've been focusing on working with folks who are not getting the health benefits from our mainstream system. We didn't think we were really enough down the road that we would be green at the end of the accreditation process. We assumed that it would be an opportunity to highlight what we're not doing very well, and then to use that as a learning and opportunity improvement. So we asked across every site and program to consider these questions that you see on the slide. What are the barriers to services in your program? What can you do differently to remove those? What can we do differently to reach people who are marginalized? And how can we support people in those situations? This is where the fun started. Just beginning this conversation in our region gave us the opportunity to meet with different groups of people and talk with them about this standard, because it wasn't, as I say, one program or one site. We were looking into all sites and programs to answer this question on this priority population. And we got some really interesting responses back, including that these aren't folks that we normally see, right? So we had some sites and programs that were saying, we don't work with this population, so we're not sure how to answer this question. That gave us the opportunity to pull the equity conversation into this standard. And so when we were out there doing these visits and meetings with different parts of our organization around this standard, we worked really hard to tie the work we were doing with this standard to our strategic plan. The WRHA had just rolled out their new 5-year plan. We are, by legislation, have to produce a 5-year plan, strategic plan. Health equity promotion was a big part of it, and the regional equity lens across all sites and programs were a big part of it. And for the Winnipeg Health Region, population public health has a lead role around the issues of equity and equity health promotion. The WRHA strategic plan, in the next slide, you can see that we've got strategic directions that do impact individuals living in the social and economic margins. So our strategic directions around enhancing patient experience, improving quality integration, involving public, doing research, building sustainability, engage service providers, those were all the kind of sticks in the ground. We said to our partners in different sites and programs, ask yourself questions about how you're doing work with this population through these lenses. Use these 6 strategic directions to ask yourself, are we giving patients the kind of experience that we want? Are we doing some quality improvement work? Are we properly integrated to do that work? How are we hearing back from the public who's experiencing what we're trying to do? Are we building sustainability, or is this a one-off? We thought that it would be really positive and powerful to bring the strategic plan together with the population health and wellness standard, because we had just rolled it out and we were already starting to kind of turn people's minds to, how do I do my work in healthcare to meet these strategic directions? If you look at the strategic directions, you can see some of them may not be sort of immediately understood as the work that we do in healthcare, particularly from an operations perspective. The other, I think, really galvanizing language that we were able to pull forward was the vision and values that were part of the strategic plan. Healthy people, vibrant communities. You can see that we put equitable care for all in that vision. And this was a very, I think, innovative opportunity to bring equity forward and to put it in our plan and to make it an expectation that people understand what we're talking about, to create some opportunities to learn what that means, and to actually put in our values equity promoting conditions in which every person can achieve their full health potential. These were very important conversation starters in the work that we were doing. So Population Public Health, as I said, was the host program for this standard, and this was done in partnership with the Housing Support and Service Integration area in the Winnipeg Health region, because in the area I have responsibility for, we do focus on the population that is marginalized and experiencing homelessness. This next slide is very busy. I'm just going to gloss over it so you can sort of look at it another time, but this really does highlight the approach of population public health with the social determinants that my other presenters have talked about a fair bit. But these are kind of, it's a bit of a roadmap, if you will, on issues that we want people to think about and talk about in their accreditation process. So the quality improvement initiatives that we brought forward as part of this work, the accreditation activities, partnership and collaboration across the sectors, and challenges and opportunities, that's what I'm going to talk about now. So the first thing that we did, we had accreditation chair meetings throughout the accreditation process. So there were roughly about 60, 70 people that were identified as accreditation chairs for their sites and programs. And we had monthly meetings, and at these monthly meetings, the Population Health and Wellness Standard was a standing agenda item because, as I said, it wove through all of the other standards and accreditation features. And we had lots of discussion at that table, as I said, about folks wondering, how does this standard apply to me? So specifically, without naming programs in particular, we had some folks saying to us, as I've said, we don't see people who are homeless. So we're not sure how to respond to that. Or we don't see people who are low income, so we're not sure how to respond to that. And we were really challenged to frame it differently so that they were asking themselves, not what do I do when somebody who's homeless needs to be discharged and doesn't have anywhere to go, but why don't I see people who are homeless? Why don't people who are marginal and who live marginal lives come to my service? So it was really turning it on its head, not just what do you do for individuals that actually supports better health outcomes for that population, but why don't you see them? That's the beginning of the conversation. And so it was a bit of a pushback on, is this relevant to me? Do I need to respond to this? I don't have anything to say to it. And instead what we did was Hannah and I both went to many programs and teams to have a conversation with them about how this is relevant and how it's relevant for all of us. And that part of the equity conversation needs to be this streams through all of our work all the time. And so it's not a thing that lives by itself in a separate program. Equity belongs in one particular place. It doesn't belong in one place in our region. It belongs everywhere. It needs to thread through all the work we do all the time. And so it was a very different way of looking at things than what our partners in our work have been accustomed to. In one of the events, we actually asked somebody of lived experience, a gentleman who is the chair of the National Lived Experiences Circle in Canada and who lives in Winnipeg here, who's had the experience of homelessness and mental illness and addictions and came through after a lot of work and a lot of help over many years to a place in his life where he's healed through his journey and is in a good place and ready to talk about his experience. And we brought him to a workshop event for all the accreditation chairs just to tell the story. And there was so much to his story that clicked for people that made our job so much easier. It really isn't about standing in front of the room and explaining the social determinants of health or how equity is different from equality. Bringing somebody in the room to talk about their experience and their barriers in trying to get the help that they needed was the, I think, trigger point that we needed for people to start thinking differently. And I would say that was a seminal point in time in our work this past year around equity and around accreditation, where we got a lot of buy-in and a lot of understanding in a way that we didn't before. So while it's baby steps, it's certainly baby steps that are being very productive now that we've got an actual person that people are thinking about when they sit down with their teams and ask the question, how is this our work? Other activities that we did were the roadmaps. Now, if you're familiar with the accreditation process, you know that most of the time the action plans are based on the required operating procedures. With the Population Health and Wellness Standards, there were no required operating procedures. So really challenging to build a roadmap. So you can see how it becomes both a challenge and an opportunity to think about how do I build equity into a plan when I don't have any idea of what should be included in that plan. So we did a lot of work. We had a couple of large workshops, one about equity, one about the roadmaps. We brought people to the workshop around the roadmaps. We brought people who we're calling equity champions, who sat at each table with each team. We said that folks coming to this workshop will come out with a draft plan, and that's actually what happened for people. There was great conversation. There was a lot of healthy debate. But having that champion at each table, helping folks work through that planning process was really effective. So moving on, the accreditation activity were standard. We had the on-site survey, and then we had the tracer process on April 18th of 2016. And you can see in the slide what we actually did. So I'm not going to read through that. What I do want to sort of highlight is the second to last bullet where it says tour, visit, and observe. We actually brought the surveyor out to one of our homeless shelters to meet with the transition team that works out of that shelter, as well as a health outreach and support team that comes from our department in health and works with that population. And the surveyor met individuals in the community who had been supported by those programs. She met with the team that works out of the shelter, and she met with the team that works out of health, that all do this work in an equity focus for better health outcomes for that population. That was very impactful for her. She talked about it at the meeting afterwards as one of the best opportunities she's had to kind of see equity in action. And I think that really shifted her experience to a much more positive experience. And you can see in the next slide when we got our actual accreditation results. So here's where, you know, I sort of reflected at the beginning that we thought we were going to come out on the pretty low side here. We were actually 100%. So population health and wellness standard of the 39 criteria, we met all 39. That really surprised us. And while that normally would be kind of cause for the happy dance, right, and maybe some celebration and that sort of thing, we were scratching our heads about this, and frankly, we're still kind of scratching our heads around this, because what it tells us is what people are saying they do and how they're framing what they do is disconnected in some way from what our citizens who try to access our services are experiencing. Some of our programs came out green on everything, and one program in particular we know very well from our community has an impossible time accessing that service. So we have to ask ourselves some hard questions. Who were people thinking about when they answered these questions? How is equity understood? Who do they think a marginalized population is? How much interaction do they actually have with that population? And all of these things are, for us, they're good starts. They're good conversation starters. We recognize that we're in the very early days of doing this work. And so while we were working without ROPs, we were working without required operating procedures, we were working in an environment that we'd not seen before in Winnipeg, where everybody was being accredited at once, and we were streaming this particular standard through every site and program. The successes from our point of view was really being able to start this conversation and make some headway in understanding how to provide service to the marginalized populations that we were talking about. So in the last slide, challenges and opportunities, I think one of my colleagues on the webinar had said earlier, maybe the same thing in a lot of ways. Reflecting back to everybody coming out, 39 out of 39 on this particular test, language and framing of the priority population, do we understand what we're talking about when we talk about advantages and disadvantaged populations? Collaboration across our service sectors, very difficult for health on their own to change social determinants of health. So those partnerships are really critical, and who we're working with. Leveraging accreditation process to further this conversation is what we've done, and I think we've done that really well. So some of the things that we have in place now, since then, we're developing a championship group, a table of people who put up their hand to say we want to continue these conversations, we want to figure this stuff out. And it's interesting, in a consultation with our public community groups, they've asked for the same thing. They think that it's important that we have advocates and champions around equity in healthcare. So we're glad to be able to move that forward. We have in the WRHA a Health for All coordinating committee that looks specifically at equity issues across our region and works with partners, inside health and external partners, to forward and foster an equitable model. We also, out of that coordinating committee, we have 3 working groups: partnership, knowledge, and learning and engagement. And the partnership group in particular works with partnerships outside of health to work on those other social determinants. We need to bring community groups into this conversation. We need to work across our sector in different ways, and I mean our community health as well as our acute care. This needs to be a shift that happens across our sector. If we just make this change in one place or we make a little equity program, we're not going to see the kind of population health benefits and different health outcomes for the identified population that we're really invested in. So understanding those are our learnings, and understanding those learnings and moving them into action is where we're at right now. We also have developed some training, which I know my colleagues have also talked about. So we've got some health equity workshops developed for staff. It's called Health Equity, What Is It Anyway? Which I think is a good characterization of kind of where we're at with the conversation. And I think that's it for me.
That's great. Thanks so much, Sharon. There's so much in there, and even though I know the Winnipeg context quite well, I think I always learn something new when I hear your team, the folks there present. So I really appreciate what you shared with us today. And we've been lining up some great questions for the presenters. So just before we get to the questions, though, I have a final poll question for all of our participants. Let me just advance to that slide. So one of the reasons we wanted to talk about accreditation today was because we know people are using it to try to advance health equity. We wanted to hear a little bit around what's been happening and how that's been going, even though we seem to be in fairly early days for it. So my question for everyone on our webinar today is I want to get a sense of your agreement with this statement. And the statement is accrediting the population health and wellness standard, and I'm just asking about that particular standard because that's one of the Canadian standards from Accreditation Canada, regularly in every health authority, health unit in our province territory would significantly advance our health equity work. So I'd like to know whether you agree with that and to what extent you agree with that. So if you can let me know what you're thinking about that, that would be really helpful. And if you're not sure, we see a few people who are saying not sure or don't agree. I'd be really interested to hear the kinds of thoughts you have about this. If you can pop some information down in the chat box, that would be really helpful. So we have about 40% saying they completely agree, another approximately, keeps changing, another 30 to 40% saying agree somewhat. So we've got some pretty good agreement. We have one person saying they do not agree, and then we have about 10 people saying they're not sure. So that's kind of what I was expecting, just because the idea of accreditation, certainly in Canada, in the public health context, is interesting, and we have different structures in Canada between the health authorities and the health units. So, I'm going to want to hear more from folks around that. So if you can add some stuff in the chat box, that would be really helpful. Okay, so I'm going to close off that poll and move over. So just a reminder that we'd like some questions for presenters, but they've been coming in, so please continue that. And we do have some discussion questions that we prepared in advance, just in case we didn't get questions from you, but we've been getting a lot of questions from you, and I've been kind of grouping them into putting like questions with like questions. So I'm just going to put a couple of questions together that were related to accreditation. And I think, Robin, if I can put you on the spot right away, because I think you'll probably have a really good some really good thoughts around the question that we got around the evidence base. So there was a question around what is the evidence base to support accreditation, and I think this relates to another question that we got was, so that's great, accreditation, but what's the outcome? Has it actually impacted equity? What's the impact or outcome of accreditation on our particular question, which is related to health equity? So I'm just going to ask Robin, can you maybe take a first stab at that, and then if any of the other presenters want to add to that, you can go ahead before we move on to the next kind of cluster of questions.
Sure, I think those are great questions, and they're definitely in the forefront and concern to the Public Health Accreditation Board. We're doing a couple things to establish some evidence-based around it. One is that we have a series of research questions and surveys of accredited health departments, and we ask them what impact has accreditation had on your health department. So it doesn't quite get at the evidence-based of moving the health equity needle, but it's in that direction because we learn from health departments that the entire process of accreditation really led to incorporating more quality improvement into what they did and how they did it, and did expand how they looked at health equity. The other thing that we're doing, and we're at the very early stages of this, for accredited health departments when they apply for reaccreditation, we're going to be asking them to give us specific health outcomes measures that they choose, that they will report to us when they apply for accreditation, reaccreditation, but then they will report to us every year. And our objective is over time to look at the measures that accredited health departments are tracking and develop a core set of outcomes measures that we can track in a collective way and look at the evidence base of how accreditation impacts on those measures. So we're at the early stages of developing that evidence base, but it is definitely a priority for us.
Yep, that's great. Thanks, Robin. And I imagine that your reaccreditation work is going to be an important part of that because you're trying to track change in part.
Exactly. Yes.
Yeah. No, that's great. Thanks for that. So, Joanne or Sharon, do you have anything you'd like to add to the question of evidence-based and outcomes from accreditation?
Not particularly. I mean, I think for me, because I've always been interested in making change, you know, I think that you have to measure it. It's like key. I mean, it's great to have plans and it's great to have all of these things, but you want to feel at the end of the day that you move the needle. And so I know my first day on the job here, I was like, okay, like let's set those measures. Let's set the targets. Like I wanted to just start with that kind of thing. And then people did say, okay, slowly, you know, whoa, lady, like, hang on, we got to educate people, got to make everybody on, like, there's a whole process. So I'm like, okay, but I feel like now we're at a critical time where we are ready to set those targets and measures and see what we can do. And I think that, you know, by the time it comes around for reaccreditation, I think we would be well poised to at least share what we've tried to do, what we've implemented, and what we have been able to impact and achieve. So it's very much on our mind and something that we're like literally like in this moment shaping. So I'm excited to come back and talk about it, you know, maybe in a year or two.
That's great. Thanks for that. We've been getting questions around, you know, what are the accreditation processes that are really focused on improving health equity, and we are fairly early in this process, I would argue. I don't know, Sharon, do you have any kind of last words before we move on to another question?
I do. Thank you. I was going to just say that for us, the dovetail that I tried to draw in the presentation between the strategic plan and accreditation is where we really were able to bring the conversation of equity to the forefront. It is early days for us to be talking about targets and outcomes. We're doing a lot of work, particularly through population public health, around where are some of the best practices. A lot of this has been kind of chewed on by folks before us, so we're looking at where is this going well to use accreditation to leverage that kind of action. But The Winnipeg Health Region Strategic Plan focusing on equity was so challenging for us to get the conversation about equity going. It lives and breathes very well in certain pockets of our organization. As you can appreciate, the programs that work in the inner city, the programs that are focused on our Indigenous populations, population public health by definition, but it lives in pockets. And if we really want to impact and not create a bit of a funnel for people so that wherever they show up in the region, they end up being sent to a program or a place that works with people like them, quote unquote, if we really want to shift that needle so that there's equitable access and equitable outcomes, then we need to have the difficult conversation about equity as opposed to equality. And in Canada, that is not an easy conversation to have. You're poking a bit of a sacred cow when you're saying we're moving away from, maybe a bit from universal delivery and towards universal outcomes. And that's a shift in thinking and a shift in practice around that thinking that we're in early days on. So I actually think the accreditation process leveraged our ability to have that conversation and start asking people to think differently so that a year or two from now we'll be talking about what we're doing differently. And I'm pretty confident that we'll have outcomes that substantiate that.
That's great. Thanks, Sharon. And I'm going to get to the question around targets and data, so nobody needs to panic. There's been a lot of questions coming through about that. But just before, just to finish some of the focus on accreditation, in particular accreditation in Canada. It was great to have an example south of the border, but accreditation in Canada does look different. And Sharon, you did mention that this was the first time that the entire health authority was going through an accreditation process. For people who've been working in public health in Canada, you likely have been through accreditation as part of a particular focus, for example, maternal child, and that accreditation often happens around maternal child, so public health gets pulled in as part of that overall system accreditation, but very rarely do we actually have a quote-unquote public health accreditation. So there's been questions that have come in today about, you know, what is accreditation, who delivers it, what are the timelines, and in particular in this Canadian context. And Sharon and folks in Winnipeg, I know that you've been involved in accreditation over the years. This is not new for you. Is there any kind of high-level comments to put this in context that you could provide for, and where you think that accreditation on this area is going in Canada?
Well, the accreditation happens here every year. I think I've got one of the slides there that identifies the actual organization, Accreditation Canada Momentum, and they provide an opportunity on an annual basis for us to report on our outcomes and our capacity around standard operating procedures. So they actually designed and developed in partnership with our departments of health the required operating procedures for specific programs and health delivery. And up until this year, we had in Winnipeg, we had accreditation every year, but usually just a few programs at a time. So maybe mental health and medicine or surgery in a hospital site, and maybe one of our community health agency partners. It being the first time that we've gone through it, everybody all together, I think one of the things that I did mention was that it was very galvanizing in bringing people together. To be honest, having been through accreditation in both ways, where it's just a few sites or all together, I thought it was great, everybody doing it at once last year, because it really did put us all in the same boat. And there seemed to be more investment and energy then for us to all come out with our best effort. And I think the most important part of accreditation is what happens after accreditation. And not just the report that you get that tells you whether you've been accredited or not. That's a big deal. We're required to be accredited in Canada, so it matters that we do pass. But when they identify where we have work to do, that's an opportunity for us to actually get some of that work done. And for the most part, that's That's stuff we all want to do anyway. It just gives us the landscape to prioritize it. So I think that I would hope to see that process again, to be honest.
That's great, thanks. And if we had more time, we could certainly go into more detail. But I just want to make a note that we had some comments earlier on today from our colleagues in Quebec who were really quite curious about the accreditation process, and makes me wonder if maybe it's being undertaken differently in Quebec. So there's a really nice further in-depth quality improvement accreditation conversation to be had in Canada, it sounds like. So thanks very much for that. So there was a lot of questions around the importance of data, reliable data, equity data, patients at the patient level, the client level, as well as at the population level. And then there was a particular question around target setting, you know, for whom, over what time, those kinds of things. So I don't know who might want to jump in on that. Joanne, you did already comment on the fact that that is kind of where you wanted to go, but you're moving in that direction. Do you want to just finish anything about that?
I did want to make a comment about that, because that's sort of a caveat. So we do have what we call community health assessments, and we have something called community health improvement plans, and we also have our Live Well indicators. So I talked only briefly about our Live Well San Diego vision, but we do have, it's not that we're not tracking, it's not that we're not, I mean, we have tons of that already. I just want to be really specific when I was saying about the moving the needle on health equity specifically. It was really like internal, like branch specific, like really drilled down in on that equity, disproportionality, disparity piece. But I'll put a link up on here to our Live Well indicators, which show some of those broader social determinants of health and how we are tracking that. And I also do just want to mention that we have a great a community health improvement. It's a CHIP and a CHA, which looks at what are the concerns and what's the status in the community and how we plan to address those. So there are things happening, and what I was referring to is specifically around what our Health Equity Committee is doing.
That's great. And just a quick follow-up question then, that things are being tracked and measured, but what about the idea of setting targets?
Well, we do have targets. We have the 2020 targets. We have the thing that I was referring to was around the metrics, and that was around disproportionality and disparity, and that's specifically for each of our branches of our public health department. But you'll see through the Community Health Statistics Unit and then this link that I'm going to put up there that we have, I mean, we wouldn't have been accredited if we weren't looking at population health data and tracking things and setting targets for other things. It's just that we have multiple layers of that going on. And so it is being done, I guess is what I wanted to say.
Right. Okay. That's really helpful. So, and Sharon, any thoughts, words of wisdom with respect to data and targets and all of those related questions?
Yeah, I think like my colleague had just indicated, we also work off of community health assessments, which again, we're legislated to do every 5 years. And we're putting up a link now for people that you can actually see in the community health assessments. They're by community area as well as general Winnipeg health region, which includes Churchill. And you can see the indicators that we use to actually measure the health and the health outcomes for specific populations. And we're using the data from the community health assessments to drive some of the indicators that we're now dovetailing into how we're measuring better health outcomes. So the better health outcomes are not just set by us as an organization, but they come from the community health assessments, which are designed using community health agency data and community health data. So this is coming from the population. It's coming from local health involvement groups, which are small committees of community members who help us with the community health assessment and who work with us as consultants to provide that kind of input. To be frank, the development of metrics and targets and indicators for health equity is the whole sector is in the early days. Right now, most of us are working across Canada, are working on understanding where we're at with health equity and being able to draw those indicators into models of delivery. And now we have to figure out how we measure if those changes in delivery models are actually impacting health outcomes. And I don't think we're there yet, but there's a lot of work going on around that.
That's great. Thanks, Sharon. And so I just want to wrap up with one more little cluster of questions to get a few thoughts from folks before we close this webinar. And this really does in some ways relate to delivery and what are we delivering and who are we delivering with. So we had a question about how are community coalitions engaged, the importance of partnerships in doing this work. And that was a particular question for San Diego, is funding provided, that kind of thing. We also had a question around policy. What are the policies that are moving forward our work in this area? And then, of course, what is our delivery of those policies? So how are we in public health supporting those policies? And then how do we capture that in accreditation? So that's all around that bigger question of working with others, engaging and working cross-sectorally. So maybe, Joanne, I can just start with you in that question around coalitions, because it was very specific for San Diego, and then any other final thoughts before we wrap up from the other presenters?
Okay, so we could almost come back and do a separate presentation just on our partnerships, because I'm really proud of that. And I have to tell you, when I first started with the county, they have a video about Live Well San Diego, and I was really quite moved by the video because I had never seen such comprehensive, integrated, multi-sectoral approach to public health and health in general. And I was really, really taken by that because I've been talking about that for years. Housing is not separate from health, is not separate from education, is not separate from the economy. And these guys got that, and they had a vision for that, and I was really impressed. And so just in a nutshell, that county vision is supported by what we call Live Well San Diego partnerships. And so if there's an organization that has the similar vision mandate to ours, we would bring them on as what we call a Live Well San Diego partner, and there'd be a proclamation, and we'd have a supervisor that would officially welcome them into that partnership. And in a tangible way, for example, on November the 3rd, we're having an event where the partners will come together and on different tracks. We're going to be brainstorming about how to move things forward. For example, I'll be in the trauma track, so the trauma-informed track, and people across the region who are all stakeholders who are interested in helping move that forward will be getting together to do just that. And so we work collaboratively with this network of people, and it's not just CBOs and NGOs and health people. These are people in the private sector, they're hospitals, they're businesses, they're organizations like Catholic Charities and others who we just all want this region to thrive and be safe and have our citizens be healthy. And we're all trying to make that happen in our own respective ways, but under this collective umbrella of what we call Live Well San Diego. And as part of something that I think mentioned already, we have these community health assessment plans and community health improvement plans, and we have regional offices that engage with stakeholders in each region to identify. They look at the data, they say this is what the data is showing right now, what are you concerned about, what do you want to do, and then together they craft their improvement plans, and they're by region, and then it gets rolled up into one broader plan. In terms of funding, I know that was a perennial issue, and it's across the board, I think, in a lot of health and social services sectors, but no, we don't provide funding to partners to come to our meetings, or I don't think so, not to the best of my knowledge. Is there I don't think that exists, but I could look into it, I guess. I just think it's more of a collaboration and partnerships and people that are recognizing that they have the same mutual goal coming together to make things happen.
Yeah, great. Thanks so much, Joanne. So we could have a whole other webinar on funding this work. So I see that we've come to the end of our time. I'm going to close this off at this point by saying a special thank you to Robin and Joanne and Sharon and all the folks behind the scenes who've made this webinar possible. A really big thank you to everyone who participated today. The chat box was full of comments and questions, and we're going to be capturing that and sharing that back to you. And I see some people who should probably connect. So I just want to mention that that's part of what we see as the role of our webinars at NCCDH, is getting people connected together. So if anyone is looking to connect with anyone else, please be in touch with us. We're happy to help those conversations happen, and are delighted when people can support each other. That's part of our work as we all work towards improving health equity. So you will be getting an email with a webinar evaluation. Please, please, please do take the less than 5 minutes it takes to do that evaluation, because we really would benefit from your comments and feedback. With that then, thanks very much to everyone who participated today. If I could just have the presenters stay on the line for a minute while everyone signs off. And I'm really looking forward to our next session.